Good morning and welcome to the Health Leaders Patient Clinical Experience Now Online Summit. My name is Chris Cheney. I am the Senior Clinical Care Editor for Health Leaders and will serve as your moderator for today's event. Our next session of today's event is titled 4 Key Elements of Patient Clinical Experience, sponsored by Midmark. Thank you to our sponsor and to you and our audience for participating today. Before we get started, I have a few housekeeping details. Our program will be 60 minutes in length. Note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar in the upper right of your screen. Here we have listed the event program guide for you to download that provides topic and panelist information from each session, along with materials from our sponsor. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists. Tom Sweeterman, Chief Medical Officer and Vice President of Clinical Affairs for Midmark Corporation. Ghazala Sharif. Good morning, Tom. Ghazala Sharif, Corporate Senior Vice President and Chief Medical Officer for Acute Care Operations and Clinical Excellence at Scripps Health.
Good morning.
And Claire Zangerly, Chief Nurse Executive, Allegheny Health Network. Thank you all for joining me today. And with that, let's get into our discussion. First question is, how can you ensure the patient experience is as peaceful and restful as possible? And Ghazala, why don't you start us off?
I'm happy to start us off. That's a difficult one only because the hospitals in general are noisy places, right? And so we've done a lot of initiatives at our sites. Some of them are very simple. One of them is it's simple but elegant. We bring around a cart, just like they do on the airplanes, at nighttime, announcing that it's quiet time. And so we offer our patients eye masks and earplugs and aromatherapy even, and dim the lights in the hallway, just as a reminder that it's quiet time. And we've gotten great response out of that one. The other thing that we do have, staff, believe it or not, we are very noisy. We like to get together at the nurse's station and talk about our weekend and nights and things like that. And so we've put in a yacker tracker. Some of you may have seen that before. It changes colors, just like a red, yellow, green light when the quietness goes up and when we start talking too much. And interestingly, just the other day, the yacker tracker picked up one of our those pneumatic devices delivering labs and things like that, and it clattered and it went off. And so it gave us an opportunity to have engineering come in and fix that device. The other thing we're doing, though, besides those simple measures, is a sleep hygiene protocol. There are definitely patients that do not need to be woken up every 2-3 hours for vital signs. That is something we have to get our physicians to sign off on, clearly, because the last thing you want to do is not pop in a patient that needs monitoring. But that will help, especially with the patients who come in, for example, with just a simple, gallbladder surgery. They definitely don't necessarily need to be woken up on a continuous basis. The fourth measure there is actually combining efforts. We go in all through that. We get your vital signs, and then lab comes in an hour later, and then somebody else comes in, and then we take them to x-ray. So bundling care is going to be really important as well. And then we give the patients a copy of their schedule every day. Some of our sites are rolling out bedside interactive care, which we can talk about technology later, but they know what their schedule is. And so if it doesn't make sense, they have an opportunity to say, I really like to eat breakfast at 10 o'clock instead of me going to x-ray at 10 o'clock. Is there a way to adjust the schedule around that as well? And so those are the things that we're working on. We actually also listen to the voice of the patient. We use a 48-hour phone call discharge policy that we have put in for several years now. And we ask them specifically about quietness at night and what can we do differently. And so we're making adjustments based on that. Some of it is as simple as the carts going through at 3 a.m. So we've looked at all of our carts, put in the wheel covers on the cart so they're not noisy, and then just really working with our staff. So it's the best that we can do. It's really hard in the shared rooms, but a lot of times we have to go in and talk to the patient in the other bed and said, can you use your earplugs for watching the TV? Because we want everybody to have a peaceful night. So there are some challenges between a shared room and a single room, but we're working on all these initiatives. Claire, you probably have things to add around that as well.
Well, those are all great tactics too. We too do the lights down from 3 to 4:30. It's a signal. It's a signal for the patients. It's a signal for families and staff. And we've had a lot of adjustments since the pandemic and actually inviting visitors back in, because we got used to it not being so noisy, and then the noise started going back up. And we do see that in our experience scores and how that does affect the patient. It affects their recovery. It affects just the chaos of a hospital is always going to be there, but how do you take that chaos down and make it more manageable? It's very important. Hearing the voice of the patient, asking them what's important to them. A lot of times we don't want to close the door. We want to keep the door open so that we can have that access and see what's going on. And when you have house staff, residents, interns, fellows coming in and out, you have to be able to control that, all while making sure the patient gets the care that they need. And just every unit in our organization, we feel like is its own little neighborhood. What works for one unit may not work for another unit, depending on the acuity of the patients. And we give our staff the ability to do what works for them. And we have best practices that are shared across the organization. And that in and of itself has helped us create a mosaic of what does it look like to have a restful environment for the patients. It's also important that the patient does know what's happening. That in and of itself reduces their frustration and chaos. And we do that through our new models of care, our blended nursing model. And just hearing what the patient has to say about the noise. And yes, we do congregate at the nurses station and make a lot of noise. So I love the idea about the yacker tracker. I don't think I would pass that one, but I love that. That's a great idea.
I was the loudest one, frankly, on grounds. It was me. It was me making all the noise. I'm so excited to see everybody. But yeah, right. It works really well.
Yeah, I'll jump in real quick on the outpatient side, which is where my principal focus is. We're very attuned to the fact that care interruptions and the intimacy of that provider-patient needs to be established and maintained, that whether it's data clicks or whether it's noisy equipment or whether it's interruptions in the room, that they can't find the right piece of diagnostic or therapeutic equipment. We really focus on the fact that when that patient and provider are together, that's a very significant moment that we need to maintain all that intimacy and communications and data access. So even on the outpatient, which is a little more fast-paced, sort of turning kind of scenario, we very much are aware that we got to make sure that human element is not only maintained, it's absolutely maintained at all costs.
Anything else on this question? Great. How can you conform to well-established standards for disease care and design patient-centered systems such as continuous glucose monitoring? And Ghazala, why don't you start us off again?
Sure. So we put in continuous glucose monitoring, really. So COVID has done some hard things that we talked about visitors, but it's also given us a chance to really work with our technology. And so we were trying to limit the number of times that our staff had to go in and out of a room. And so this continuous glucose monitoring was one of those examples. It's such a nifty device. It's implanted it's very small into the patient's abdomen, literally gives us continuous glucose monitoring to an iPad that's outside the patient's room. And so it's cut down our point of care testing to literally once a day. And we only do that just to make sure that the device is actually working. So that's one way that we could design patient-centered. Again, they get more rest because people aren't going in and out of the room, and we're able to adjust their insulin levels or whatever we need to do in real time versus waiting for those blood checks in between. It truly is continuous, and we identify areas quicker. That's one thing. The other thing we're doing around guidelines for care, when I took on, so back step a little bit, I took on the chief medical officer role about a month and a half before COVID hit. And so you can imagine what that looked like. Tom and I were talking earlier about just all of the work around that. But we needed to make a change. We were not improving as fast as we wanted to do especially around these established guidelines. So what we did was looked at several different programs, and you all are very familiar with these 3 government programs: value-based purchasing, hospital readmission reduction program, and hospital acquired condition reduction program. Those are all financial programs around certain standards, right? You want to reduce readmissions and decrease infections. And we put together what I call, I'm an ER doc by training, put together what I call sprint teams. There was a chief operating executive, a physician operating executive, and someone from each of our 5 hospitals on these teams around a specific disease or a complication. So we had congestive heart failure, we had COPD, surgical site infections. I see there's a question from us about surgical services. We had surgical site infections, some of the key areas that we needed to really focus on. And the word sprint means sprint. It's not that you process and you go over and over again. And we established checklists for each of these conditions. Here's what should be done in every single case. So catheter-associated urinary tract infections, here's what should have happened. And if it didn't match up, then we got a way to go back, and we'll talk about risk reduction a little bit later, but it matches that up very nicely as well. So that's how we make sure that we're establishing the guidelines, looking at evidence-based reviews to make sure that our checklists actually align with what we're supposed to be doing. And then the staff has something to check off when they're going back and doing chart reviews. So that's a way to bring it all together under one umbrella. And frankly, it's been working so well. We were, not to brag on ourselves, but we're on the Meredith top 15 healthcare systems list. We used to be IBM Watson. You guys may remember that, Truven, IBM Watson, and now it's called Meredith. But a lot of that is due to this standardization of work across the system, because you can't have one hospital doing one thing and another doing another one. So that's my answer to that question.
One thing in the ambulatory side that's really interesting to where you're going there is the ambulatory and acute care systems are now becoming far more integrated on the disease care model. That these readmission standards and adherence to medications and programs really start at the hospital, but it really is the executive functions are within the ambulatory sector. So in the ambulatory side, we have the same types of programs. And one problem I would have entertained some feedback from the other panelists is when hospital systems acquired a lot of these ambulatory docs who are private in nature, they weren't accustomed to the protocol standardized care models that are very common in the hospital setting. And we're increasingly seeing those come to the ambulatory side. And it truly is synergistic and complementary, because one can't exist in effectiveness without the other being also attended to. So in the ambulatory, we're really trying to design systems and workflow and our ecosystems that allow for that disease model to hit its exact protocol dimensions across the board. So pretty interesting how they're coming together.
Well, I love that you said that. Go ahead.
Yeah.
I was going to say, it did bring our entire system together. You're absolutely right. For readmission reduction, we can't do that without our ambulatory partner. So that's part of the checklist is, did you make an appointment, within 7 days? And that's part of that discharge phone call, a 48-hour phone call. Did you make your follow-up appointment? So absolutely, you cannot do this without the ambulatory partnership that we've developed as well. Claire, go ahead.
Yeah, I think what we are seeing is the confluence of acute care and ambulatory care, post-acute care. We are blurring the lines between those two, and I love to see that. I worked in acute care for 20 years, went to post-acute care for about 8, now I'm back in acute care, and to be able to see how we're evolving better for the patient, on behalf of the patient, I think is very important, because they're in the hospital for a very short amount of time. Their life is lived way outside the hospital, and if they have a bad experience in the hospital, it informs how they continue to take care of themselves and how they continue to manage and deal with the healthcare system outside of that. So what we've done at Allegheny Health Network, and I think it's worked very well for us, and it's helped us tremendously with managing the different disease care processes with our patients, is implemented navigators, disease-specific navigators. And those navigators cross both inpatient and outpatient lines, and they all have a book of business. Who are the patients that I make sure that I track and take care of? And that definitely improves the patient experience, because they have one person to call. They have one person to help them, quote, navigate. And that does contribute to an excellent patient experience. And it teaches them that they have accountability in taking care of themselves and managing their disease process as well.
Anything else on this question? Excellent. How can you shift from one-to-one models of care to team-based models of care, such as team nursing? And Claire, why don't you start us off?
Well, we could talk all day about models of care and the current challenge that we have with staffing our inpatient units as well as our ambulatory care centers, and how nursing is at the center of that. We have a tremendous nursing shortage right now that actually started with the Affordable Care Act when that was put in place, which was a great thing, but we weren't prepared for the influx of patients. Then on top of that, we had the pandemic and all of the issues around staffing in the pandemic. So what we've had to do is think about how do we continue to meet the demand of taking care of the patients who need the care and be able to staff that appropriately. So we have to look at what kind of models of care are out there. Patients still need their call bells answered. They still need to get the care that they came in to the hospital or to the ambulatory setting to get. So one of the things that we've put together is what we call blended nursing. And blended nursing is a team of caregivers who have a cohort of patients on a nursing unit who they're taking care of a cohort of, maybe, depending on the acuity of the patients, maybe 8 to 10 to 12 patients, but there's a registered nurse who serves as a team leader, a licensed practical nurse, and a patient care technician. So you have that team that's covering that cohort of patients. There should never be a time when a patient's call bell is rung that it can't be answered in a timely manner. And it's also very helpful because that team knows what their lane is. They know what their scope of practice is. They know what each of the team members is to do for that group of patients. It also helps with burnout because the team is there they're covering each other. If somebody needs to take a meal break, which sometimes they haven't been doing, they're able to do that. They feel comfortable doing that because the team is there. What we've done by implementing this blended nursing care is we've seen an improvement in patient experience. The patients get the attention that they need. The call bells get answered. We've seen an improvement in quality, a reduction in falls because there's always a set of eyes on the patient when there needs to be that set of eyes. The controversial thing around our blended model of nursing is inviting LPNs back into acute care when for many years acute care settings have said no thank you to LPNs. You belong in post-acute care and only in post-acute care. We found a place for them in acute care. Everybody has a scope of practice. So I think if you're intentional about it and if you have buy-in from your nurse leaders, buy-in from your physician staff to understand what this model of care would look like, you can transition to different models of whatever fits. We are not going to survive in the current environment if we are not flexible with our models of care, if we are not open, if we are not willing to try new things. We either fail fast or scale fast. And I think that's very important for all of us to have that perspective going forward. And we've actually been very successful with our blended model of nursing. And I know that other organizations have tried different things. And I think that it's important for us to recognize that everybody contributes. We're an interdisciplinary team. And how do we bring the teams together to deliver that care? You guys are probably doing something at Scripps that is very similar.
Yeah, actually, it's interesting to hear your terminology. We call ours model. We started, our CEO several years ago had this vision of using or making everybody enjoy their work a little bit more because we were having nurses do things that were really not at their standard of care, right? They should be performing at a certain level. We need them to be at the bedside explaining to the patient what's happening in clinical terms, right? Communication about medications is a great example, sitting with the patient during discharge instructions. And so have everybody working at the top of their license. So he had coined this before even COVID hit and it came in very handy. So we call ours model care. So we've got model medical surgical care is where we started. Now we have a model OR and now we model ICU. And that, exactly what you said, Claire, is bringing everybody together. On the medical surgical units, we have a nurse, registered nurse that is in charge of that team, one patient services representative, a patient care assistant. They're assigned to 6 patients, so there's overlap. right, between the nursing teams, and so you can cover each other. But what I like about the model is that it's truly multidisciplinary. We round in the morning with the entire team. In fact, I was just on rounds and we had a clergy member on that team as well. So we can start discharge planning. It's not just about daily care. It's about planning for that discharge on day one, because we all know that during COVID, we've had difficulty placing patients afterwards in the post-acute care space, right? So skilled nursing facilities, for example, we're not taking patients. So we had to start early. So we have case managers, pharmacists on that morning team. And then we escalate any defects. I don't like calling things defects. I call them opportunities for improvement. But what did we not do that day that we could? And we were actually saving time on length of stay. So if you think about it, with the shortage that you described, it's not just nurses, it's everybody. We have imaging tech shortages as well. And so if we can't get an echo, for example, then the patient has to stay in the hospital longer. While I was on rounds, somebody needed a PICC line placed. Well, if you didn't take care of that, it would have been a Saturday. Then you call the team in. And so what do we do up front to really try and minimize that length of stay? And so that team nursing model has come in very, very helpful, especially during our surges. So the team is ready to pivot. In California, we have nursing ratios, and so we have to get a flex waiver if we need to. So the current ratio is one nurse for 4 patients, and then we have to get permission to flex. But having this model in place already led to that team nursing concept during COVID. So it's very well orchestrated, and we're going back and kind of refreshing everything one more time now that we got a little bit of a lull from COVID. So it's nice to hear that the model is working well at your place as well. Part of it is telling the patient, though. I think what we forget to do is we put in these new programs, but we forget to tell the patient what we're doing for them. And so we are making a point of making sure that our patient care assistants do go in and tell them what we're here for. We're here to make sure that you reduce the number of times you have to push your call button so we can anticipate your needs, and getting in there on an hourly basis, whether it's the nurse or the patient care assistant, to make sure those needs are being met in real time to reduce the number of times that call button has to be used. Tom, anything to add?
A couple of things. One, I think the technology is going to help. There's real-time locating systems that help bring those teams together, so you have some ability to coordinate those team dynamics at the acute care side. And one thing I've seen, I got enough gray hair to talk this way, is the team model of care across the board is really gaining steam. It was, for a long time, it was sort of this provider-patient concept and the doctor all-knowing kind of thing. And now we're getting into a much more distributed care model, which I think is extremely healthy. And I think it's the only way to solve to your points about the conundrum of access to the right type of clinician. You just have to keep that person at the top of their license and distribute the work to those that are capable of providing it. And we're seeing, again, I hate to hone on the ambulatory side, but the same thing's happening. The complexity of the ambulatory environment to a team-based environment, whether it's a pharmacist, an ancillary provider, a clinical coach, you just see a lot more dynamics of workflow complexity because you just have more people involved, but it's a healthier experience for the patient. And I think that dynamism is something that I think is a ticket out of medical errors, also a way to kind of improve the efficiency of the provider itself. So I'm excited about the team model, and I think it's clearly the demonstrated effectiveness of the future.
My only suggestion is don't call it team nursing anymore.
Nurses don't like that.
They don't. All of us old school nurses, we remember team nursing from back in the day. That's why we named it blended nursing, because we're blending our teams together. So feel free to use that term.
Yeah, no, I like that a lot. I'll add the other thing is having the staff engagement, right? And so we, on the rounds, I was interested in that when we rounded in the intensive care unit, my CEO was with me to rounds. They did it differently than usual doctor rounds. Usually, right, the doctor starts off with rounds and we run and we basically talk about everything and everybody else's area as well. And so they did it differently at one of our campuses, a kickoff site. They actually had the staff report out that was responsible. So pharmacy reported out about what was going on that day, and then respiratory therapy reported out. And then the clergy person spoke, and the doctor was last. And I found that fascinating. So I said, why did you do it that way? And it says, because the doctor takes everything away and the staff doesn't feel like they're involved in the patient care. And it's really turned around that entire environment of everybody feeling like they truly are part of the team. And so just the team dynamics is really important as well, not to forget that, and make sure everybody feels included. There's no point rounding in a big gaggle if no one has anything to say and be part of that process.
That's great for culture. That really is. And right now, we need whatever is going to be great for culture.
Exactly.
Great. What kinds of systems can you put in place to achieve medical error reduction? And Claire, why don't you kick us off again?
Well, I think there's a variety of systems you can put in place that will help that. And it just depends on your organization and what works best for your organization. But you can't put a system in without having just culture. And just culture means that it's okay to report a medical error. And we see this all the time. We see that these things come up in the news. They happen a fair amount, and people are afraid sometimes to raise the concern of that they made a mistake, whether it's a medication error or anything like that. So I think it's extremely important to give people permission to admit their mistakes so that you can prevent them from happening again, especially in this current environment where we have a lot of people, new graduate nurses, new residents and interns coming in who haven't had the clinical experience that they've had in the past because of the pandemic and being prevented from being in the hospital during the pandemic. They've used simulation and things like that, which is terrific, but they also don't have the same experience that we're used to them having before the pandemic. So having that just culture is really important. And of course, having a very nimble system that they can report in. We use the RL system. Sometimes when people are learning it, it takes time for them to learn it, to what goes in there and how does it work for you. That system is working for you as an organization, not you working for that system. So I think that is very important when looking at the types of systems you put in place.
A couple of things on my end. It's really about automating what you should automate and being very attuned to the safety and efficacy of that automation. Transmission of data from a manual entry to an electronic system has proven to be error-ridden. That if there's a blood pressure 133, they'll route it to 135, and it does make a difference sometimes in trend analysis, and it can be the wrong type of data for the clinician to make a judgment on. So really, what we're trying to do on the ambulatory side is really optimize all that data. There's terabytes of data occurring in that site, and just making sure that when it is available, that it's done in a way that's very, very consistent, that's verified and validated as being verbatim to the actual reading, and then making sure that the clinicians can have that access and distribute that data in as few clicks as possible. It's just the more you ask that clinician to do on the human side, the more error reduction you're going to get. So again, automation isn't the key to the end of everything, but it does truly help automate, reduce the errors at the point of care.
I appreciate you saying that about the best practice alerts. You don't want to overdo it so that everybody, you do get alert fatigue, and that is a true thing after using Epic for so many years. But that is one way. So the best practice alerts have been helpful. But what we put in, Claire, to your point of transparency around errors, what we don't want to, everybody does root cause analysis, and then the site or even the unit learns what happens, but we don't necessarily spread that across our system, or we didn't before. So our CEO, Chris Van Gorder, asked when we took on the new CMO role is, can you put together a different structure so that we learn from any errors that are made? You can't, you're not going to, I love the concept of zero harm, but let's be practical here. It's almost impossible. Human nature is human nature. Things are going to happen. But how do we assure that that doesn't happen at another site? And so we put together what we call Executive Risk Reduction Council. That's the two CMOs, my ambulatory partner, myself, our chief legal counsel, and our compliance officer. And we put in a senior director to manage our risk department. And we review these cases. And what we found is that there's some commonalities. And we've actually, somebody's, oh my God, that could have just as easily been me. And we were able to make system changes. One is on the consent form. We had a surgeon perform a procedure that wasn't already on the consent form. Well, usually nothing happens with that because it needs to be done, but you have to go back. And so that's spread across the system. Don't do anything that's not on the consent form unless you go back and revisit that. So it sounds simple, but you can see how that error could have been made by somebody else. And so we do that, and we're finding that there's a much faster escalation to myself when something does happen as a site because of this process. They notify me in real time. We have our circle call, as we call it. And so we can give direction pretty quickly now. And so it's all about being transparent, because I do think there's ways to reduce errors, but there's also some inevitable, and I can't talk today, inevitable things that happen. The sprint teams have been helping with this medical error reduction in the first place, right? Because if you follow that checklist, especially for surgical site infections, did the patient use the CHG wipe, for example? Did they do all of that ahead of time? You'll actually end up with less surgical site infections, and then we've been proving that over and over again. So the checklist is helping reduce some of that in advance. So a couple different things that we're doing around reduction of risk.
And that transparency is so important. We really focused on, let's talk about it. You know, we have safety huddles, and those huddles are important, and everybody's got a voice in that huddle. And I think the huddles give us an opportunity to explore opportunities for improvement, to look at new ways to deliver the care, and just give everybody a voice. So I cannot speak highly enough about the whole transparency and just culture piece of reducing medical errors in the first place and achieving that reduction just overall.
Excellent. What kinds of systems can you put in place to reduce medical errors in the first place? I think, Claire, you've already spoken to this, but I mean, if you want to add anything.
No, again, I think you have to do, of course, what works for your organization, but it also has to be communicated widely. It can't be in pockets. It has to be communicated from the bottom up and from the top down and supported in both ways. So the communication is very important about what is your philosophy of reducing medical errors, and how important is it to you? It's not just about, you know, the risk that you're trying to avoid, which you are, and it's the right thing to do. And that is why we're in patient care. We're do no harm, and that's what we should focus on.
Anybody else on this one?
I think we talked about the infrastructures and having checklists and things in place. The other thing that we do is that we do report out to the board. And so I think having that level of transparency all the way from the front lines up to our central board lets people know that it's okay. We understand when a mistake is made, but what can we do differently? And so that another layer of transparency. And so we report out of the board every month in our quality meetings if there's been a fallout case, and there's ownership. And I think once you own the issue, you can make system changes as well.
And does the board participate in the process, or are you just reporting up to them in terms of accountability?
A little bit of both. And so they won't be they're on the credentialing side of things. So they absolutely are involved in any clinician type issues, but they're involved in designing our board report, for example. You know, how do they want to see the data? How to hold me accountable for our patient experience and quality? They help me design the board report because they want to hear specifics, and they ask terrific questions. They participate. It's not just a report out. They will ask some pretty pointed questions about what happened, where did it happen, you know, what are you doing differently? And it may sound harsh the way I'm explaining it, but it's very collaborative. And the team loves coming to present to our quality board meeting because they know they're going to get asked some really good questions. And sometimes they ask questions that we haven't thought about before. We go back to the drawing board and incorporate their advice. So it's nice sometimes to have an outside person looking in saying, have you thought of this? Versus, you know how it is when you're in the middle of it. Sometimes the clear path isn't always visible to you.
Great. Anything else on this question? Moving on. How important is the element of design to the patient clinical experience? And Tom, why don't you kick us off?
I think we all know in clinical care is a very complex process. It involves very complex and increasingly complex clinical science. There's team-based care, which we talked about earlier, bringing multiple clinical provider types into the care experience at the point of care. Then finally, there's payer models that are changing the game as far as value-based care and the way physicians and provider groups are paid. So when you think about that level of complexity, there's all those layers you have to consider. You must design the systems to meet the needs of the environment in order to achieve the optimal outcome. So I think design is critical, and I think we've seen this demonstration, whether it's the design of your iPhone with Apple or whether it's design of an automobile with some of these high-end automobile manufacturers. It's a design that really brings in all those elements of safety and effectiveness and performance. So when it comes to my world of the ambulatory side, design is everything. It's the centerpiece of how we think about the design of the care experience from a clinical aspect, design of the experience from a humanistic sort of interaction aspect, from a comfort and aesthetic. There's just a lot of elements to that add into the entirety of the experience. And at the end of the day, you don't have a good experience if you don't have a good outcome. So the designing systems to allow for error reduction and protocol adherence and nuanced care for a specific issue at the point of care is really critical. So design has become sort of the centerpiece of how you think about that environmental dynamic between where the patient and doctor-provider experience occurs. So I don't have specifics for you. I can just tell you that it's the thread that goes through it all.
I can give you some specifics, Tom. When we design our buildings, it's really important to have people that are on the front lines helping you design things. So think back to the days, especially in the ambulatory side. I know for sure, working in those rooms, that they put the computer, this is everywhere I've worked. It's not just at Scripps, it's other hospitals as well, because they've done a lot of moonlighting. The computer is over here and with your back to the patient. I don't know who designed, I'm sure you've heard this across the country, who designed that room, so we have to make shift. It's twisting my body so I can see the patient. You really have to have the front lines who are doing that involved. Simple things like where you put the elevator, for example, that's noisy. When we have the robots come up with the food trays, are you going to put that robot in the elevator right where the patients are? Redesigning where the nursing stations are. Claire, I'm sure you have input on this as well, because we all know that that's where the noisy place is. Do you have to have them right outside? So we've done a lot of redesign work. We now have, the computer and a workstation outside in our single, ones that we're building now, right outside the patient room, right? So we don't have to go back to the nursing station and everybody congregate in the same place. And so that kind of design is actually important, but you also don't want to have people so spread out. So we had at one hospital, the pharmacy's way down, the pharmacy, where you get the meds is all the way down the hall. Well, running down the hallway isn't helpful as well. And so the practical side of things, I think, is really important to have somebody involved in from the get-go. The other thing with design, Tom, is to think ahead. So when we went, people are going to go now. Remember the whiteboards? We still have the whiteboards, literally the whiteboard in our rooms. But at some point, that's going to go electronic. And so when we looked at the design of the new building, it was interesting. People say, well, just put it on the TV screen. Well, that's not practical, because I might want to watch TV and watch a movie, but I also want to know what my schedule is for the day, who my care team is, and all the things that we have on the care board right now. But then it's not visible. So you have to have room for two of those. You have to have room for the TV, and you have to have room for your electronic monitor telling you all these things that we're doing. And people hadn't thought about that before. And so the wall was too tiny. And so those are the things I think people don't think about, but practically speaking, we got to learn as we build our future hospitals. And we're working on a building, with the Seismic Safety Act in California, we have to rebuild our hospitals by 2030. So we're incorporating the patient aspect into some of these things, and trying to predict where technology is going to be in 10 years is also an interesting challenge. But those are the things to think about from the patient experience.
Jump in on a few specifics on the ambulatory. So we design rooms and simple things like the door swing. You want the door swing to open in a way that shields the patient from visibility if somebody's walking down the hallway in case you're undressed. The design of the equipment you're using to make sure it goes to the lowest height possible, so that the 5'2" lady can sit as well as the basketball player in a comfortable manner to be properly positioned. And same thing when it comes to the intimacy, to make sure that you pointed out earlier that the computer monitor and the eye contact between doctor and patient, it has been a bit of a casualty with EMR. So having a situation where you can design a setup where the doctor and the provider are actually still maintaining eye contact while the typing is occurring is important. We were involved in a situation where we were watching and observed a care experience, and the doctor was facing the opposite direction, typing and asking about this patient's suicidal ideation. Now, that's just bad body language when you're back into the patient asking about, considering ending his own life. So those are the types of design elements that really come into play, and it could create some poignant interaction improvements if you do it right.
Well, not everybody has the opportunity to build new hospitals and things like that. So there's all kinds of opportunities for people to look at their current spaces, say what works in terms of aesthetics, what works in terms of convenience for both the staff and for the patient. So I think that as we're looking at our facilities, and a lot of us have very old facilities, and we only have so much to work with. But it's like with your house. You don't want to move from your house, but you might want to remodel. How do you make it a better experience? What I know is that for us in some of our older facilities, having supplies so far away from where you need the supplies is a detriment because it's great for the nurse to get their steps in or the physician to get their steps in, but between the patient room and the supply room, they could get stopped 10 times to do other things, and that lengthens the amount of time between delivering the care to the patient. So creating an environment where you have everything you need close by is a patient satisfier as well as an employee satisfier. That's what we've learned. We did have the opportunity to build a new hospital that we just opened in March. And before we did that, we literally created patient rooms in a warehouse, and we involved all of our staff. Mm-hmm. And we said, wait a minute, how many steps is it from here to here to here? Just as if you're building a new home, it's the same approach. And I can tell you the pride of ownership of the staff, having had so much input into the placement of things and how their work would surround them, has made a big difference in the satisfaction. And they're speaking for the patients in the building that hospital too. But what's also interesting is we have what we call PFACs, Patient and Family Advisory Councils. We included our patients in that as well, and they gave us some great feedback on that. It's amazing what feedback they'll give you when you actually ask them.
And don't underestimate the IS component, the information services part, Tom. That's really important, right? Because if you think about it, I could cut down the noise right away. But to Claire's point, we have some older hospitals that, the functionality isn't quite there. You lose connection when you go into the basement. And so we have to do overhead pages, right, for traumas coming in. And you think about that from the patient perspective. I don't want to hear code blue 2:00 in the morning or code strokes coming in. And that is not rest. To our very first question, that's not restful or peaceful. We actually we were doing a little cute little noise when a baby was born. Well, that's great, but don't do that at 2:00 in the morning. I love as a patient, it was fun for the staff to hear that a new baby was born, but that's not great for patient care. So IS is really important. We are putting in bedside interactive care. Some of you may have that already, but it's so dependent on having the information services team work well because it's all digital, right? And so we have to think about how do you incorporate that, especially into some of our older buildings, because we want the patient to get the same level of care, whichever hospital they go to in our system. And so, you can't have one standard at one of our older hospitals and something else at one of the newer hospitals, because that doesn't go well.
Great. How does the equipment used at the point of care impact the patient experience? Is current equipment meeting the needs of today's healthcare environments? And that's another question for you, Tom.
Yeah, it's inherent in how we think about the exam room setup that we do, and really boils down to something as simple as designing the form to follow the function. And very recently, the American Heart Association, the American Medical Association, and others joined hips on how to properly do a blood pressure. And you may think that's a very simple concept in care that's done every day all the time, but it's really quite specific now. It's about positioning and making sure the back is supported, the feet are on the floor, the cuffs at the right height. There's 7 steps that you must follow, and really it falls to the equipment being able to do that in a proper way. And then when you do take the blood pressure, a proper rest period followed by averaging is something that will dramatically impact the blood pressure. In fact, a study by the JAMA just a couple of years ago showed an 8-point drop if you're not adhering to the simple wait period. And any one of those measures of back not supported or legs crossed or talking can have a 5 to 10 point change in your blood pressure reading, and usually higher. And that, as you would know, as providers on the call, can change a therapeutic interaction very specifically. So designing equipment to make sure that it's hard not to follow the protocol in the right way is really the path forward, because we mentioned before the staff issues that are involved, that it's new staff are turning around faster than they ever have. So having to train people is one way, but having the equipment simply do it for you is another. So we're really thinking about that as how can we make it so that it's difficult to do it in the wrong way. And then on top of that, when the data does get achieved, making sure that it reaches the electronic record or the clinical point of view at exactly the right time with the right exact data so that you can make a precise, accurate diagnosis. So it kind of goes back to this patient experience ends and begins with the ability to get a good outcome, and design the equipment to bring that to the clinician every time is really kind of where we're trying to put our focus.
I can chime in just a little bit. I think we're going to need more technology, to be honest, with all the staffing issues that we have had, and that we don't see an end to this probably for the next 18 months or so. We are starting to we had 150 some people in new employee orientation, but we're looking at technology. I mentioned the robots. We actually have these cute little robots. I can't remember their names, but they go down to our cafeteria and they pick up the trays. And it's loaded up and they program it and it goes up to the floor. So that's cut down on staffing. Now you may think, well, that was very expensive. Yes, it was, but it came in very handy during these last 2 years because we needed that. Had we not had that technology, I don't know how we would have actually survived. We were moving staff all over the place, but that's an essential function. You have to have the food trays to our patients. We're looking in the cafeterias at, you can weigh your foods and cutting down on the number of staff. So anything that we can do to cut down on the staff that we could deploy elsewhere. We're going to need the staff, but what can we do to make life a little bit easier so that we can deploy staff where we need them is going to be even more important now with the current healthcare needs. And so just something to think about, that what we have done, what we are noticing is there's so many new products, medical devices that are coming out that we had to put a stop on some of that. Me too, I want it. I want to try this new device because it's coming out and it's pretty sexy. And so we've got a committee put together called the Medical Effectiveness Review Committee. And what we do with technology there is we go to the service lines and when they want to try something new and have them vet it. Let's look at best practice. Let's look at evidence-based literature. Is it really that much better? And does it really help you with the patient outcome? What do the studies say? And then they have to come up with sort of this escalation process to the Medical Effectiveness Review Committee. We call it MERC. And they have to explain, why do you want this? Is it really that much better? Or is it a me too? I just want it because I want to be the first in San Diego to use this new device. And that's something that we have to keep tabs on. The costs have gone up so much. Revenue's coming down, costs are going up. How are we going to manage some of that? And so we can't be the candy store anymore and really evaluating what the current equipment is. Does it provide the same outcome? Is it more efficient? Is the new one more efficient? Well, that would come in handy because then we can do things faster in the OR, for example, if I can get through the case faster. So we're looking at things in a different way than we did before, really looking at profit loss, really back to the old budget days, and really what is the outcome before you buy this new device? Is it really going to help on the downside of things, the downstream effects? Claire,
I think since the pandemic, we have seen the digital market explode. I can't tell you how many emails I get every single day with somebody telling me they can solve all my problems digitally. And we've decided that we have to come with the open eyes and say, is this real or is it Theranos, honestly? Because they cannot digital cannot solve every problem, but we can't as humans, we can't solve every problem too. And I think there are certain digital solutions that will help us tremendously. And we have to, I love what you guys are doing in terms of having open eyes, committee-wise, looking at this at your medical executive committee, whatever you're doing at Scripps. I think that's a great idea because you probably have the voice of a lot of different people saying, this will work, this won't. Right. We have to think, too, as our revenues are going down, all of these digital solutions are six figures. And if you're not going to get, is the juice worth the squeeze of every one of these solutions? But how do we make it much easier? I think that the voice of the staff is very important because not only do you bring them the solution, but when you start to implement the solution, is it more of a burden to implement this solution than it's going to help you do things? So I think eyes wide open, going in with, we have a new chief digital officer that we're very excited about, but we're also very excited that he's conservative enough to know that we have to be looking at every solution to be multi-pronged. It can't just fix one thing. It has to be multi-pronged.
Great. We're going to move into the Q&A portion of the program now. So we would now like to invite you and our audience to ask live questions of our panelists. As a reminder, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. So the first question is for Claire. With the blended nursing model, do you also have designated a charge nurse that does not take patients?
It just depends on the unit. It depends on the acuity of the patient. It depends on what types of patients are on that unit. Some do, some don't. It's unit dependent.
Yeah, I'll chime in. In general, the concept would be to have a charge nurse who is free to help and not have to take direct patient care. But with COVID and the staffing shortages, we are now having to see some our charge nurses, supervisors go in and do actual patient care. So it's not exactly the model that we wanted, but we have to do what we have to do. So, and I've seen that as I round as well. But ideally, the charge nurse would be able to take a step back and be able to be the orchestra director.
Great. Next question, I think Ghazala could kick this off. What was the financial cost to implementing continuous glucose monitoring in your facilities?
Well, we actually got, I have my paper right here, we actually got external funding to help kick us off on that front. So that helped for sure. And then we started at one site. And then the other thing is that we actually, Dexcom is a company that we worked with, they actually provided us with an FTE data analyst so we could go back and make sure that things were being done in a productive way. And so that's how we got started. There was another question in there about how you charge. Remember, a lot of these patients are DRG based, so it's a roll-up charge. So I can't tell you exactly how much you charge because it's all rolled up under that one fee for the visit. That being said, we definitely cut down on lab tests, point of care testing, and people going in and out of the room. But the external funding is how we got started. And then as we rolled it across the system, then we just adapted it into our budgets for the following year. We always start someplace, just like with sprint teams, we start someplace, we pilot it, make sure it works before we invest in the entire organization and make sure it works. And then we're able to do it that way.
Yeah, and that's a follow-up question, which was how is the continuous glucose monitoring initiated? Did you start with a trial on a particular nursing unit first?
Correct. We started at one unit, and then we spread in that hospital, the entire hospital, and now we're spreading to our other hospitals as well.
Great. What equipment considerations should healthcare organizations keep top of mind to enhance accessibility? And Tom, why don't you take that one?
Sure. Yeah, as you can imagine, most of these patients that have accessibility issues are some of the most needy as far as healthcare conditions go. Obviously, there's a reason for their accessibility issues, whether they're elderly or chronic diseases. So designing systems allow them to be placed on the exam table, whether it's a low height table for a transfer from a wheelchair to the exam table. A couple studies have shown that patients in wheelchairs historically have not gotten thorough exams because of that. So we owe this population the same opportunity our able-bodied persons have as well. We're also looking at ways that we can make sure that the access between the doctor and the caregiver are done in an appropriate way so that if there's a procedure at the head and neck, that the equipment is designed in a way that allows the physician to be right there next to the patient and not have any barriers between him or her, and allow that patient to obtain that sort of surgical condition care in the best possible circumstances, even if it is in an ambulatory environment. And finally, making sure that we have mobile workstations so that we have the patient-centered experience to allow for that accessibility of patients who are put in a position where they have to give an intimate conversation with their doctor, and we allow that sort of conversation to occur in probably the best way possible. So accessibility is really critical to ensuring that those who need the care are getting the right kind of care.
Anybody else want to tackle that accessibility question? Great. I'm going to move on to the next question. I can't remember who talked about sprint teams.
That was me.
Okay. Well, can you share with our audience more details about the sprint teams?
Sure, and I was going to answer to the other question as well about accessibility. As we talked earlier a little bit about what can we do to reduce the manpower, and so our CEO reminded me earlier today that we are putting in the new hospitals lifts. So for those patients that we have to physically lift in and out of beds, what can we do that's more using technology to help us with that, right? So we have lifts put in to help with that, and we've seen all kinds of different models for around that one. So things to think about long term is how do you protect your staff as well from some of the injuries. So we talked about risk reduction. We're also looking at how to reduce workman's comp type injuries from doing the direct patient care. The sprint teams, I'm happy to answer emails after as well, depending how much information you want. So the sprint team, so I'll walk you through one example. So we had congestive heart failure was one of our key areas, readmissions that we wanted to focus on. So we got together a chief operating executive, a physician operating executive, a cardiology specialist, and then somebody from the ambulatory side, so a physician on the ambulatory side because we needed a handoff, and then a person from each of our sites was on that sprint team. And we literally looked back at cases from the year before, looking at what those readmissions were about. And that's how we developed our checklist. Did the patient start these medications before they left the hospital? Did they have a follow-up visit within 7 days of their discharge? How do we make sure they get to that appointment? Could it be a virtual visit? And so we developed this checklist. And then we wanted to make sure the management system, so that was step one. Step two is the management system to make sure that that's being done. And so we talk about congestive heart failure readmissions on our huddles, if that's a fallout case, for example. And then we review all of those cases. We have a joint quality leader meeting before we meet with the board. We talked about the board meeting to discuss the cases that have fallen through. And so it's all continuous work that the sprint team does, and we ultimately report up at our board meeting. So that's the general concept of it. But Chris, I don't know how to give people my email address, but I'm happy to answer questions that way if that didn't answer it well enough.
That's all the time we have for questions today. In closing, please note that if you registered for the closing session of the summit titled The Complete Playbook for a Positive Patient Clinical Experience, a live clickable link will appear at the close of this session to take you directly over to that program. If you have not registered for that program and wish to attend, you will need to click the link and fill out the registration form to gain access. I want to thank our panelists once again for excellent discussion and our sponsor, Midmark, for making this program possible. Finally, thank you to you and our audience for participating. We hope you enjoyed the session and look forward to seeing you during the final session for this summit.